Hey, let's get after a couple concepts from a couple case studies from patients that I saw this week. Number one, let's talk about thoracic rotation. So we had an older fellow looking to improve thoracic rotation and related to the golf swing. Let's think of the first thing that we'll get after is typically rib position, okay? But we have to think of where that rib is moving from. When you use a passive approach and descend the ribs, or if you're using the breathing pattern to use the diaphragm and the exhalation position to pull the ribs down, if the ribs are moving, where's the joint? Because I don't think we're moving from the sternum. I don't think we're moving from the chondral connections anteriorly. I think we're moving where the joint actually is, which is posterior at the costovertebral joint, which usually splits two segments above and below. So when something appears to be a mobility issue because it's consistent across different positions, you test in an unloaded position, you test in quadruped, you test in sitting or kneeling, you test in standing, and it appears to be the same across the board, I do think that we're thinking about a mobility issue. However, if breathing works, it really couldn't have been a mobility issue by the definition using the adaptive changes across the soft tissue, because adaptive changes in soft tissue cannot change immediately. I call that neuro-locked. And going back to the ribs for the purpose of thoracic rotation, I think if we can begin with an LDOA, and in this case we used LDOA rib 10, which if it's going to work in this situation, you should see a result immediately. And we did, which is a great sign, because really taking advantage of probably more of the neurological impact to the fascia, thoracic rotation to both directions increased immediately. So now, next session, we'll go back to rib 10, but then we'll follow up both east and west. We're going to go 10, 11, and 9, 10. So we turn one exercise into two, and then we'll probably also run some mobilization of the intercostals. And we're just going to stay in that area and then move north or south based on what we see next. But always thinking when it's clearly mobility by definition, because it's consistent across all different positions. If something works quickly that doesn't cost you a lot of time, it's worth a try. Now, I don't know that that's always necessary, or if that's something that has to be done all the time. We could have gone to rib grab, we could have gone to quadruped lumbar locked, we could have gone to twist and tilt. There's a lot of other mobility drills that target adaptive changes in the soft tissue. So we went LDOA first. We're not going to use those. We're going to go this other route. If it didn't work right away, we probably would have been more traditional there. Next patient I've really worked with him a long time, and he's really restricted. So I think this is not a clinical suggestion here, but something that's more sociological. I am not immune to patients or clients making whimsical decisions. And this fellow went to a big-time golf tournament, got a lesson, back is all jacked up, and I said to him first thing, like, did this golf pro look at how you moved? Because I have no suggestion, just like how I've talked about surgeons. I have no idea what the correct golf technique approach is. However, I kind of know what the wrong one is, and when the wrong one is one where your back hurts, my first suggestion is, does he know what your hips, your upper back, and your shoulders are able to do? And the answer was no. And it's like, man, so I take those opportunities. I obviously have every reason to be disappointed, and I'm disappointed that that my patient's back is bugging him when we're working on other mobility issues. But man, even in this situation, what I think when even though I've worked for a long time, he wasn't connected enough to the goals of what we're trying to accomplish, because he should. I feel like he should have known. So I take responsibility for that, even though this doofus golf teaching pro told him, oh yeah, he just needs to get his back stronger. I'm sure that his limitations in thoracic motion and glenohumeral motion had nothing to do with this compensatory action of what is now a pretty mean quadrant position. Extension with rotation is really what triggers his pain. So I'll use that as an opportunity to continue to try to create analogies and continue to show that nothing wrong with having a lot of other new team members, but everybody still has to have the same global thought process in how we want to accomplish things. So that one hit a little bit. So I'm also, I feel good being able to share, hey, things don't always go the way you want them. We talk about a lot of cool things, but I think it's also important to be able to talk about mistakes. That is a bigger message for anyone you listen to. Again, I loved when back at Perform Better when Scott asked, what's part of your BS meter? Part of my BS meter is that the people that you listen to, they never tell you about how they fail. Probably frauds with intent to deceive. Definition of fraud. So I like being able to say sometimes when things don't go well, because it gives you opportunity to not let it happen again. Can't get better if we don't fail. And then lastly, also related to golf, my guy is saying he wants to be able to really be able to put some more force into the ground, and he was talking about these box jumps where you are rotating midair. So let's say you're facing to the left and you do a 45-degree turn to land up on the box. In seeing these, they scare the hell out of me, for one, because I don't think that's what's happening in the golf swing from a mechanical level. The rotation is happening above the foot. It's happening, in the hip. And I think when you see, it's just understanding a little bit about biomechanics. I'm not sure if that's ever been studied, the foot rotary mechanics of these rotational box jumps or lateral box jumps. So when we put together 4 days, we're going to do outside leg lateral box jump for distance, and we're going to do box hops. But I think that if we move laterally, I think we're probably closer to the actual mechanics that we're seeing in the swing to be able to put big force into the ground. And with all of our box jumps, we do not go high. We just arbitrarily, this one is no rhyme or reason other than what size boxes do most people have. So if we're 6'1" and below, we're going to use 18 inches. And if you're above 6'1", we'll use 24 or 28 inches. We're never going any higher than that. Obviously, there's nothing wrong with going higher, but what we're focusing on is getting further away from the box. So we call these broad box jumps because that's what you're doing. So for me, I'm 5'4", so I'm looking to get 64 inches away from an 18-inch box. And that way, and this is the first time we saw it, you really see folks really getting triple extension there where you do not see it as you're crouching and trying to get up. And I've done those too. I mean, I've got up to a 43-inch box, which at my height, I think is no joke. That being said, I think it's much more of a training effect and you actually feel, that you're pounding into the floor when you get that big box, the big broad box jump. So we're going to look at that lateral, and we're not going to be twisting midair. If we feel like we need to twist, we're going to do that with other drills. And I'm excited to see if we can get some results here on some swing speed or other parameters that we can measure objectively with the swing, because that's the last case study, extremely high level golfer. So we're going to need to really dial in and measure what we're doing. But again, another opportunity to try some things, and I think these make sense, and I certainly don't think there's a downside where we're really going to jeopardize gameplay. So hopefully that makes sense. We talked a little bit about neuro-locked, which is what looks like a mobility, but by definition, if something changes immediately, it probably wasn't mobility. Neuro-locked is when a stabilization strategy, usually something that's very, very neurological, not a patterning issue, but a neurological issue nonetheless. Number 2, let's talk about our failures, man. I'm really disappointed in this golf pro, and I'm really this close to saying the name of the club because I know a lot of people that go there. And then lastly, we're going to look at broad jumps to a box, a fairly low box, again, less chance of being a skin donor, even though all our boxes are cloth and a little bit collapsible. But we're going to try to gain that mechanical foot action during a rotary position by doing lateral hops and lateral box hops. So we'll see how these work out for the end. Will also happen if we do cross paths in the Crichton section of Mobile, Alabama. If anybody sees a leprechaun, say yeah.